Hello and welcome to DS Research Center. First of all, I like to express my gratitude to all our viewers for their support to our social media broadcasting by giving meaningful feedbacks. Uh, DS Research Center, as you know, that we are now operating from 6 centers pan India. We are reaching at least 300,000 viewers in our social media broadcasting, and mostly we like to spread awareness and knowledge about cancer, and we always encourage feedbacks from all our viewers, because when you uh, encourage us, we get motivated, and when you criticize us, we get a chance to correct ourselves. Today we are going to deliver a medical education program on sarcoma. And because this month, month of July is a month marked as a month of sarcoma awareness for the so this month we will doing very various programs regarding sarcoma. Today we are we are have two eminent speakers. First of all, I thank all my viewers and my guests. We are feeling very proud to have Dr. Kaustav Majumdar with us, and I personally feeling honored to introduce him. He is one of the most eminent consultant radiation oncologist of Kolkata and all over India. He is the Neil Joseph Fellow, Tata Memorial Hospital, Mumbai, and now he is the assistant professor and grade 2 consultant radiation oncologist of Chittoranjan National Cancer Institute, Kolkata. Apart from that, he is the joint secretary of Association of Radiation Oncologists of India, West Bengal chapter. And with him, we also have our dietitian Meena K from Bengaluru, DSRC Bengaluru, who is MPhil in food and nutrition. She is very popular with her with her post most popular with our viewers in our social media platform. She is very effective dietitian, I must say that. Also, our patient is very familiar to her. Me, Dr. Anirban, has been attached to DSRC for the last 20 years, and now I am cordially welcoming you both and our viewers also to be with us in this program. I just I just want to start with a suggestion first to our all viewers, that see, if one has been diagnosed with sarcoma, it is very normal to have lot of questions, because sarcoma is a relatively uncommon cancer. It is it is best, I think it is best to find an oncologist who has specific experience in diagnosing and treating the condition, as he or she will be well equipped to address our concerns. And with this suggestion, I am going to start this program. I have few questions, but Dr. Majumdar already has a very good and interesting PPT, a good presentation with him. And I will request to you, sir, please present your PPT to us, so that we can imbibe many things from this PPT.
Thank you. I am sharing my PPT.
Okay, sir.
Is it visible?
Yes, sir. Yes, sir. It is visible.
Okay. So good evening, everyone, the viewers and the doctors present here. And so today, the topic of discussion is a sarcoma, a forgotten cancer. So first, starting with the cancer. The cancer is the Latin word carcinos, mean the crab. So it's the ancient use of this word for the malignancy, the crab which spread the tentacles, and like that of the cancer also, which spread various part of the body. So the cancer names is come from the crab or carcinos. So cancer regarded as a group of disease which characterized by the abnormal growth of the cell, ability to invade tissues, and eventually death of the affected patient and the part. So what is sarcoma? A sarcoma is a malignant tumor arising from the bones, muscles, tendons, cartilage, and other connective tissues. So these are from the non-epithelial mesodermal cells. On the other hand, it is the difference from the carcinoma is that the carcinoma arises from the epithelial cells. So the term sarcoma derived from the Greek word sarx, means the flesh. By the way of sarcoma, Sarkoma, a fleshy exuberance. From there, it is sarcoma names come. So it is more common in the child than that of the adults. Sarcoma is a rare tumor, as I all know. It accounts for around less than 1% of the all adult tumor, but 15% of the all pediatric tumors. The incidence of this sarcoma is 2.91 per lakh population. On the other hand, the bone sarcoma is 0.9 per lakh of the population. And if you could divide the sarcoma, it is mainly by the two parts. One is the soft tissue sarcoma, that is coming from the muscle, fat, nerves, blood vessels, and the bone sarcoma, which are the cancer originate from the bone only. So is it really a very rare or forgetting things? If we find the literature of the malignancy, it is seen that the first ever known malignancy present in the fossils is the osteosarcoma. It is around 1.6 to 1.8 million years old. You know this movie, The Anand. So here, Rajesh Khanna was suffering from the liposarcoma of the intestine. So this sarcoma name was also there, but nowadays, due to some classification, it is more towards lymphoma than that of sarcoma. But sarcoma is there in their disease entity. The Rous sarcoma virus is the first oncovirus to have been described by Peyton Rous, for which he has received the Nobel Prize, and it causes the sarcoma in the chickens. For this sarcoma, whatever might be the rare or I don't know, but it's from 2007 July, it was described as Sarcoma Awareness Month with the yellow ribbon as its symbol. Now, what are the causes of the sarcoma? So first is the mostly unknown, that is idiopathic. Second is the radiation association, chemical, thermal association, virus associated, genetics, and part of the various syndromes the sarcoma is association. So the chemical carcinogens are important thing is the herbicides. They are very much contaminants in the agriculture, which is responsible for it. Viral infection, for example, human herpes virus 8, Kaposi sarcoma, Epstein-Barr virus, etc. Radiation. Breast cancer patient treated with the radiation as a adjuvant therapy for the treatment of the breast cancer, it is seen that the patient if live long, more than 10 years, 12 years, then and the part where the radiation has been given, the sarcoma might arise. Genetic basis, I'm not going to the various translocation or deletion of the genes, but yes, genetic basis is an important factor for the causation of the sarcoma. So how to, diagnose a patient of sarcoma? A patient will not come with the diagnosis of sarcoma always. So the patient might come in with various clinical features. For example, is the soft tissue mass, that is from golf ball size or any larger. Painful or painless lump that might occur, lump which is increasing in size. You can from the history you can take that a lump of any size in the deep muscular fossa. Abdominal pain, any kind of abdominal sarcoma which might present with abdominal pain, weight loss, and obviously the fracture, that is any bone sarcoma, it might present with a fracture. And obviously, if a patient having some surgery for a tumor and a recurrence come, then always kept in mind there might be a sarcoma or a malignancy present there. So how you are going to diagnose that? So you have to take some biopsy from the lesion and send the pathologist, and the pathologist will tell you whether their sarcoma cells is present here or not. There are various types of biopsy, but important is that true cut biopsy. It is a more or less non-invasive procedure. You can see here a biopsy gun, and this is a biopsy needle. So this biopsy needle is inserting into the lump and some tissue is taking out. And from there, it is sent to the pathologist, and the pathologist will say that whether it is a soft tissue sarcoma or a bone sarcoma or either, whether it is a benign also. So you can say these are from the adipose tissue, the malignant is called the liposarcoma. From skeletal muscle is the rhabdomyosarcoma, some smooth muscle, leiomyosarcoma, from the vascular, that is from the blood vessels, is the angiosarcoma. And also the bone sarcoma, that is the osteosarcoma, Ewing sarcoma, and chondrosarcoma. This is the part of the bone sarcoma. So after this pathological diagnosis, you have to know what is the extent of the disease in the locally. So here you can see that is an MRI of an extremity sarcoma. So here, in case mainly in the extremity and trunk, the MRI is the diagnosis of choice. On the other hand, if it is a retroperitoneal, that is the abdominal sarcoma, that is it is inside the abdomen, then CT scan is the diagnosis of the choice. Now, as you all know, as I already mentioned, that cancer is spread to the other part of the body, then and the sarcoma is also. And for that reason, we have to do the CCT thorax abdomen to rule out any kind of metastasis, that is whether it is spread to the other organ or not. Nowadays, the PET scan, it is an important scan where you can see that here a tumor present in the lower part of the femur and tibia, and it's also going to the lung. So this is a case of the metastatic sarcoma. So by PET scan, you can diagnose that whether the metastasis occur or not. Now, seeing all these MRI, CT or PET CT, we have to stage the tumor. That is stage 1, that is the earliest stage, and stage 4, that is the most advanced stage. So as we all know that this American Joint Committee of Cancer, they have a classification of various cancers. And in the soft tissue sarcoma, obviously they have divided into the trunk and extremity and abdominal. In trunk and extremity, there is a T, N, M staging is there. You can see here, I'm not going to details of it, but accordingly, we have divided from 1 to 4. And similarly, in the abdomen and thoracic visceral organ, they have a separate T and M classification, and from there, we will divide it whether it is a stage 1 or stage 4 or 3 or 2. Now, how the sarcoma has been treated. So the therapeutic goals is the long-term survival, avoidance of the local recurrence, maximizing the function, and minimizing the morbidity. And what are the departments involved? A lot of pathology for diagnosis, surgical oncology, orthopedics or plastic surgery for the surgical purpose. They are taking out, they are reconstruct the place. Medical oncology for the chemotherapy, radiation oncology for the radiation therapy, and obviously the physical therapy, that is the physiotherapy is important parcel of the sarcoma. So surgery, it is a mainstay because the main bulk of the tumor can be removed by the surgery only. Second is the radiation therapy. Because radiation is reduced the absolute risk of the local recurrence about 20 to 25%. And it is given pre or post-operatively. If pre-operatively, that is the before surgery, if the radiation is given, this is called the neoadjuvant radiotherapy. It is for the downstaging of the tumor. And when it is given after the surgery, it is called the adjuvant radiotherapy. Now, I am going to give you some basic of the radiotherapy because this radiotherapy part is not, covered in maximum. In our MBBS days also, we don't have a very limited idea in that time about the radiotherapy. So I am giving a very brief of the radiation therapy, what is it and what is the modern radiation therapy is. Okay. So what is radiotherapy? It is a treatment of the malignancy using the ionizing radiation. So it's aimed to deliver the precise measured dose of the radiation to a defined tumor volume and to reduce the dose to the normal structure. So radiation therapy is the effective tool of the malignancy for last 100 years. So there are many way to deliver the radiation therapy. One is the external way. That is from the source is present here, and from there the radiation to be given. I'm giving a depiction of the radiation therapy machine. So you can see here, it is a radiation therapy machine, external beam radiation therapy machine. This is called source side, this is gantry, this is couch where the patient lie down, and from the source side, the radiations come and treat the patient. So
sir, one thing, just a minute, sir, I beg your pardon. That can you please give a sequence of treatment? That means from a patient point of view, what will a patient do? First of all, he or she go for diagnosis after having a few symptoms.
Yeah. So I have already mentioned you here the surgery is the mainstay followed by radiation therapy. I'm just giving you an example. If you want to skip it, I can skip it.
I don't want to skip. Please carry on, sir. Okay.
So this is a radiation therapy machine where you can say that from the machine the radiations come and ultimately the tumor has been destroyed. Okay. So whether a radiation therapy is given to a tumor, you can say this is a sarcoma, there is very normal structure. We have to prevent these normal structures. And so our motto of the radiation therapy to maximize the dose to the tumor and minimum dose to the normal tissue. So there are various ways. I'm not going to details of it. Conventional from the 3D CRT, IMRT, IGRT. And the IMRT technique, it is the most important technique nowadays because we have to give the, you can see here the tumor is here and we are giving the radiation therapy to the tumor only to prevent the radiation to the outer part. So these are the various techniques. I'm not again details of it. And next is the brachytherapy. What is brachytherapy? Brachytherapy means that when the radiation given from the very close to it, then it is called the brachytherapy. I'm telling because of the fact that nowadays in our practice, we are giving a lot of radiation therapy to treat the tumor. So now the proper treatment part. So in the treatment part, it is if the tumor is resectable. For example, if it is present in the extremity or in the retroperitoneum, that is in the abdomen, if it is resectable, then surgery is given followed by the radiation therapy. It is called the adjuvant radiation therapy. And if it is unresectable, that is surgery is not feasible, then initially by the virtue of radiation therapy, the tumor mass should be reduced and followed by surgery has been given. As you can see here, there is a big tumor in the extremity, and after radiation therapy, it's going to the small and it's taken out by the surgeon. So these are the radiation therapy, how it is given. And it is second important is the brachytherapy. So this is one of our patients which is taking brachytherapy. The tumor has been removed by the surgeon. You can see here the tumor bed is here, and here we have placed on some catheter, and through this catheter the radiation pellets have been introduced inside the tumor bed and radiation therapy has been given. So in our center we are giving a lot of radiation. Here Dr. Taposh Maji, our head of the department, he is one of the pioneer of the brachytherapy, and we are doing this brachytherapy in our centers. So chemotherapy and targeted therapy is also a line of management. So when the chemotherapy is used, it has a limited role in the STS, that is a soft tissue sarcoma. But in case of the high grade and the more than 10 centimeter, it is used. And in case of the metastatic soft tissue sarcoma, this chemotherapy is used. So what are the chemotherapy drugs used? Various, for example, ifosfamide, doxorubicin, docetaxel, gemcitabine, these are used. Targeted therapy, various other drugs has been used, and nowadays there is important, I'm not going to details, that next generation sequences is important for the sarcoma management, because after in a case of metastatic tumor, when all the treatment have been tried, but next part is that we have to go for the next generation sequencing. Now I'm coming to the specific some tumor, where the tumor arises from and what are the treatment of that. So these are the various types, as I already mentioned, liposarcoma, rhabdomyosarcoma, everything. So first starting with the liposarcoma, because it is the most common soft tissue tumor in the among all the soft tissue sarcomas. So you can see there is normally a big mass normally present. So it happens in the thigh, groin, back, or abdomen. Mainly it's not painful. It's common in the men than that of women. More often in the adults 40 to 60 years of age. There are various pathological type. It is treated by the surgery along with radiation therapy. And again, if it is more than 10 centimeter and it is a undifferentiated, this is a high grade, then chemotherapy is used. The 5-year survival in the liposarcoma, when it is a well differentiated, that is a good variety is there, it is 100%. It is very important. Second is the rhabdomyosarcoma. The rhabdomyosarcoma is the most common sarcoma in the children. It is around 3 to 4% of the all childhood tumor, and various genetic mutations are the causative factor of this rhabdomyosarcoma. It's mainly made up of the normally developed from the skeletal muscles. Okay, so it is a difference from the osteosarcoma. Is the osteosarcoma from the bone, and the rhabdomyosarcoma is from the skeletal muscles. And it's a head neck tumor is the most common site. It is mainly 20% case presented with the metastatic tumor. And according to the site, the treatment to be introduced. For example, in the head neck region, if it is there, then chemotherapy followed by radiation therapy to be given. And in case of the extremity, if the surgically resectable, then surgery to be done, followed by chemotherapy and radiation therapy. If not resectable, then we have to reduce the tumor mass, that is smaller tumor mass, and then surgery or radiation to be given. Next is a malignant peripheral nerve sheath tumor. Here also it's coming from the Schwann cell. So it is normally around 20 to 50 years of age. It is tumor is we can see the tumors. Surgery is the mainstay of treatment, and after that radiation therapy to be given. Angiosarcoma, it is the, I have already told you, previously treated breast cancer. You can see here one breast cancer patient who have lived more than 12 years here, ultimately developed angiosarcoma after 12 years. But to develop the angiosarcoma, the patient have to live for that around 10 to 12 years. Okay, so it's angiosarcoma, normally 6, 7 to 8 decades of the life it is normally arising. And the treatment here also, again, the surgery followed by radiation therapy. But yes, distance failure and the local failure is much more common in case of the angiosarcoma. Leiomyosarcoma, these are another important, and they're mainly arising in the retroperitoneum. So here also the treatment is a similar, the surgery and radiation therapy. Desmoid tumor, it is mainly it's occur in the abdomen from the fibrous tissue. The treatment is somehow different. Here the surgery is the only treatment of choice, followed by we can keep the patient on follow-up. If it is unresectable, then chemotherapy followed by radiation can be given. The last part of my discussion is the bone cancer. First is the Ewing sarcoma. It is second most common primary osseous after the osteosarcoma. It is endothelial in origin, that is from the vessels only, and males are mainly affected. Various genetic predisposition is there. Important thing is that it is when presented around 30 to 40% cases presented with a metastasis, that is already get metastasis, that is the spread out when it is present. It is a very much chemotherapy and radiation therapy sensitive tumor. And it said that it melts with chemotherapy. And yes, in our day-to-day practice, we've seen that the Ewing sarcoma just melted by the radiation or chemotherapy. Again, chemotherapy and radiotherapy treatment, but the chemotherapy is used, which is a bit different. I'm not going details. And the 5-year survival is around 81% if it is non-metastatic, and around 67% when there is the spread to the nearby region. Last is the osteosarcoma. This osteosarcoma is from the bone forming cell. As I already mentioned previously, this is rhabdomyosarcoma from the skeletal muscle, but the osteosarcoma is from the bone forming cell. And I have seen here the X-ray of a osteosarcoma patient, because the X-ray is only diagnostic, is called the Codman's triangle, or rather is a diagnostic for the osteosarcoma. And this important osteosarcoma is important because by virtue of the osteosarcoma, when the treatment has been given, the patient have to lose their limb. So there is a various methods are used nowadays for the surgery. That is, one is the limb preservation approach, where the affected bone segment is initially removed, and this bone segment is taken into the radiotherapy machine, and here the high dose radiation has been given, and after irradiation, this segment is again back to the normal place, that is the where the femur or the fibula, wherever from the where it has been taken, is introduced there. So important thing is that patient get their limb back, and psychological advantage is that patient got their own limb. So on conclusion, the take-home message is the history and clinical examination is the mandatory from the initial prediction, because if you don't take the history, then you cannot predict that it is a sarcoma or whether it is a cancer or not. Surgery mainstay, but to reduce the all kind of recurrence, radiotherapy is obviously a good treatment of choice here. Metastatic disease, that is the when the patients come here, or when after a treatment the disease spread to the other part of the body, then in those cases surgery, radiation might not take any role. In those cases only chemotherapy, targeted therapy, or the other biologic therapy is taken into consideration for the treatment. And lastly, whether we have to want to forget it not, I don't know. But if you don't know what is sarcoma, what is how to be treated, how to be diagnosed it, then if such patient is come to you as when you are staying in the OPD outdoor, then you don't know the how to go for the management of the patient. As we all know that when mind cannot know, eyes cannot see. So we have to know about the sarcoma, whether it is rare or not, and we have to proceed for the further treatment for the benefit of the patient. Thank you.
Thank you very much, sir. But I just have one question, if you have time. That is there any preventive measures that one patient can take to fight with sarcoma?
Sarcoma has no proper preventive measure, but if you can just take out all the causative factor, for example, the background radiation which has been present, and various carcinogen in the agricultural products where this sarcoma might occur. If we can try to avoid these things, then we might prevent even this rare tumor.
And secondly, sir, whenever we get a chance to see sarcoma patients in our OPDs, then the general question they ask to us that what is about the prognosis? How many days I will survive, like that. So what will be your ideal answer? What we suggest to?
When the first patient, patient come, and after the diagnosis, we stamp it is a sarcoma, then we have to go for the metastatic workup. How it is spreaded or not. So what is the staging? I have already mentioned what are the stage, various stages.
Yes.
So according to the stage, we have to mention the prognosis, not only stage. The sarcoma, there are various types. I have mentioned that liposarcoma, abdominal sarcoma. Each and everything has a separate prognostic entity. Okay, for example, even in the liposarcoma, there is a well-differentiated variety, there is an undifferentiated variety. That is a grade 1 tumor or grade 3 tumor. Grade 1 tumor has a good prognosis. Grade 3 tumor has a bad prognosis. So ultimately, seeing the everything, that is the histopathology, the MRI report or PET scan report, we have to tell the patient what is the prognosis, how it behaves with the treatments. Okay, this should be absolutely, we have to tell the patient after all the reports is in our hand. Okay, not before. We have to not jump. It is a sarcoma, you cannot live, or it is a small sarcoma, you will live for 100 years. We should not jump to it. Okay, this thing should be kept in mind, and after that we have to tell the patient. If not, then patient will have as a either positive or negative thing.
Yes, sir.
Having the patient.
Sir. I understand. Thank you very much, sir. Your presentation is really very helpful to us and our viewers also. Thank you very much for your precious time. Minaji, already you have submitted a PPT to us, a presentation to us. I just want to say one thing, that whenever we get a chance to meet any dietitian, we have a question that what to eat. So I please ask you to please present your PPT. Please present it so that we can see it, and our viewers can also see it. Okay.
As we all know, cancer treatment and nutrition.
Ma'am, please share your PPT first. Share the PPT first. Okay.
One second.
Yes, it's coming, ma'am. Yes. Okay. Okay. Okay, ma'am, you can start.
Okay.
Next slide, ma'am. Next slide. Yes. This is what all. Yes.
Yeah. So
cancer treatments and nutrition are never the same.
Yeah, it is never the same for everyone. It all depends upon the type of cancer, what is the current treatment, what is the patient's BMI, his or her lifestyle, and their genetic information. So every diet need to be personalized, tailor-made, based on the treatment, and the nutritional requirement. So,
ma'am, I have one suggestion to you, that
yes,
our viewers will see that presentation. In between, if you have any question to Dr. Mojumdar, you can ask. Okay. And I am reading your PPT that cancer nutrition is an effective tool which can be controlled by patients. For example, if a patient can maintain BMI before the treatment, then it will be easy for him or her to overcome the treatment with less side effects. Okay. Next slide, madam. Nutritional side effects. Okay. These are the side effects of
These are the side effects which
nutritional side
generally
effects.
patient face during the treatment. These are the problems which they come across, like swallowing difficulty, digestive issues. They undergo taste changes. There is some reflux, bowel changes, fatigue, iron deficiency, and you can also find unintentional weight changes. To overcome this, the patient generally needs to remember 5 basic principles. First is go small. In go small, what I would say is like the patient should try to take mini or a small frequent meal or always the best. So every 3 hours, the patient should try to have a small, and if there is a variety, it's always good. What happens? This gives a support and energy and stamina to the patient. And when the patient quantity, the body could digest better the smaller quantity. And there's issues like heartburns and reflux can be
Next.
reduced.
Okay.
Yeah.
Next slide, madam.
The next,
Okay.
no,
Yes, protein
next is
requirement is
like
a very,
the
very
5
important
simple
thing.
point.
Patient always asks
No,
about
the
protein
5 simple
requirements.
point.
Yes.
Weight. This 5 simple point, where first I have told about go simple. The patient has to go simple. Next, weight. The patient has to wait when he has to wait and see when it is a hunger pan higher. When the hunger pan is larger, he needs to consume the bigger, larger meal. The remaining time, he can have a healthy snack or a protein shake. Third is the patient need to correct the digestive issues. The patient need to be a little proactive. He can just the this is the time the patient and it can affect his appetite. So like a small home remedy is always important. For example, if the patient is having a diarrhea, then he needs to include a liquid diet or more of fluids like soups, extras. So when the patient during the treatment can experience anemia. When the patient is experiencing anemia, he can try to include iron-rich foods like beetroot juice, pomegranate juice, wheatgrass juice. So last but not the least, most of the patient experiences nausea. So he needs to kick out or knock out the nausea is very important for their weight so that the person doesn't lose the muscle mass wastage. So most of the patients, better they can go for a cold
Can you
diet,
please go
a
to the next
bland
slide?
diet,
I think no.
aromatic
Okay.
diet.
Yes.
So
Yes.
these are the 5 simple rules which the patient needs to follow.
Okay, ma'am.
Regarding protein requirement, generally in the sarcoma patient, the protein requirement are pretty higher as the disease burden, and there is also because of the treatment side effect. So adequate protein, as we all know, it is very important to prevent the muscle wastage, to fight infections, and also to heal the wound healing and faster recovery and increase the quality of your life. So it's better to spread the protein intake throughout the meal rather than giving one big protein meal in a day. So when the protein intake is spread throughout the day, that will help to prevent the protein breakdown and also will promote the protein storage in the patient. So the patient at least need to consume 20 to 30 grams of protein in a meal, in a larger meal,
Yes, that is
and
very
10 to
important.
15 grams, 10 to 15 grams of protein in every small snack. So if you see how much of protein a patient need to take, for example, when a patient weighs 80 grams, we generally say calculate from 1.2 to 2 grams based on the treatment and all those things. So minimum 96 to 160 grams of protein a patient need to take during a treatment. So this cannot be achieved easily. With the help of a dietitian, the patient can be able to at least meet the minimum requirement of a protein requirement.
Just a minute, ma'am. We have
Yes,
many Hindi-speaking viewers. So please
okay.
go to the previous slide. I just want to say in Hindi. Yes.
Yes.
मैं हिंदी में ये स्लाइड जो है थोड़ा बोल देता हूँ कि प्रोटीन इज ए वेरी प्रोटीन बहुत ही इम्पोर्टेंट है, बहुत ही जरूरी है शरीर के पोषण के लिए, क्योंकि जब कैंसर का ट्रीटमेंट मोस्टली सार्कोमा का ट्रीटमेंट चलते हैं तो प्रोटीन रिक्वायरमेंट इंक्रीज कर जाता है, बढ़ जाता है, और उसका डेली रिक्वायरमेंट जो होता है, प्लीज गो टू दी नेक्स्ट स्लाइड प्लीज. यस, तो इसमें जो है कि 20 to 30 ग्राम ऑफ प्रोटीन हर मील में, प्रति मील में, मतलब जो भारी खाद्य हम लोग लेते हैं जैसे डिनर या लंच, उसमें 20 से 30 ग्राम का प्रोटीन इंटेक जरूरी है। एंड 10 to 15 ग्राम, 10 से 15 ग्राम प्रोटीन छोटा मोटा जो मील होता है उसमें लगता है। एम आई राइट मैम?
Yes,
यस, ओके ओके, थैंक यू मैम। एंड प्रोटीन जो आप एक एग्जांपल दिए हैं, बहुत ही अच्छा है कि जो इफ 80 केजी का कोई व्यक्ति है तो वो द आइडियल कंज्यूम विल बी 96 ग्राम, मतलब 96 ग्राम मैक्सिमम ऑफ प्रोटीन पर डे, यही है ना?
yes,
ओके ओके मैम, कैरी ऑन योर स्लाइड्स।
yes. Next question, just asking about prevention and treatment of sarcoma.
Yes, prevention,
Depending
yes.
on the depending upon the treatment, the patient generally requires additional calorie, protein, and fluid. This is really a challenge for a patient. When if he cannot eat during the treatment, most of the patient will not be able to eat. And if he's not able to eat the same, if he's not having the same amount of appetite as before the treatment, it is going to be a great challenge for a patient as well as the dietitian. So, as already told in the previous question, like what you have asked, like protein is pretty higher in sarcoma patient due to the disease burden. It is the adequate amount of protein is really required to prevent the muscle mass and also for the speedy recovery during the treatment. Research has also revealed that antioxidants, there are a lot of
Yes.
research papers which says that when the patients start consuming antioxidants in their diet, that helps to prevent, not only prevent, and also manage the disease condition of cancer. So the patient need to try to include more colors of fruits and vegetables. The colors of the fruits and vegetables are really of antioxidant. For example, carotene. Beta carotene is orange in
Yes. Beta carotene, lutein.
Next
Yes.
example, lutein. Lutein, when I
Next
say
slide.
spinach, turnip, greens, they're all rich in antioxidants. They're all examples of antioxidants. So to their diet, the more antioxidant they can get it. Even fruits are very high in antioxidant. Example, blueberry and beans. What we have, take the beans on a daily basis, like kidney beans, all rich in antioxidants. So patients should try to eat and prevent, and these are all help in the prevention, not only in the prevention, also in the treatment of sarcoma.
Now, dietary precaution.
You are asking about the dietary precautions. What are the dietary precautions we need to look for sarcoma patient is the patient, first and foremost, they need to avoid red meat, processed food, and limit the fast foods and sugary drinks. They should then what are they supposed to eat is basically try to eat your whole greens, more of fruits and vegetables in your diet, along with it. Eating well can help you feel better and stay stronger during and after the treatment of sarcoma.
Ma'am, is there any
limit
of sugar intake? Is there any limit of sugar intake per day for a sarcoma patient?
Generally, the sugar intake should not exceed beyond 3 spoons per day. That is the normal recommendation. Recommended dietary allowances allows only 3 spoons per day. Not only for sarcoma patient, for all overall general population. 3 to 6
चम्मच चीनी, उससे ज्यादा नहीं.
3 to 6 spoons. Yeah, 3 to 6 spoons on a general recommendation. When there is a cancer patient, to limit to 3 spoons, not beyond that. So what happens when a person drinks, for example, 1 cup of coffee, 3 spoons of gayab. So you need to think on the amount of food what they're having. That is very important.
Okay.
Only kind thing is like the patient need to be kind to your body, and they should focus on eating a healthy eating option so that they provide a good nutrient that would help their body
Okay, okay, ma'am.
being a hindrance to it.
Okay, ma'am. Okay, yes. Okay, okay. Thank you, ma'am. One thing, do you have any question? If you want to ask to Dr. Majumdar, you can ask.
These slides are very clear on the radiation thing. It was, I felt it to be, there is nothing, no question from my end.
I cannot hear you, ma'am, properly. Can you repeat it? I think connection is not good there.
Yes, there may be some technical glitches.
It was very clear.
Ma'am, ma'am, can you hear me right now? You can, if you have any question, you can write it down in the chat options. Okay, you can write it down so that we can see. Hello, ma'am. Can you hear me? Okay, I think that maybe some technical glitches is happening. Sir, one last few questions to you. That sometimes we are now, as you know, that we are now Facebook Live also. Many viewers are asking many questions, and many types of questions are coming. Can you please tell me that what are the stages? You have already detailed everything. What is actually the most important, most I think I say most critical stage of sarcoma? Most critical stage, is it third stage, or is it what stage it is?
Any kind of malignancy, there are 4 stages. Solid malignancy, stage 1 to stage 4. So stage 1 is the early stage. Stage 4 is the last stage, what is calling. So in between is stage 2 and 3. So stage 2 is critical, then stage 1. Stage 3 is critical, then stage 2 and 1. And obviously stage 4 is the most critical stage. So absolutely, according to the stage only, we can prognosticate what is the, the outcome of the patient and the survival chance of the patient.
Okay, sir. And then one thing I am like to have this, like to ask you that this question, that is there any type of sarcoma which you can say that this is untreatable? Is there any kind of sarcoma, or we can say the patient say to the patient that yes, every type of sarcoma is treatable?
Every type of sarcoma is treatable unless it is coming to the very last stage. Okay, that's stage 4. Basically, when we are going to treat any patient, we are along with the stage and everything, we have to see also the general condition of that patient. This general condition is very good, very important, basically, because the patient is coming with a stage 3 sarcoma, but yes, the patient is 80 years of old. Okay, so patient has a very poor general condition, is the performance status is very poor. So in those cases, even we have options of treating him or her, but we cannot offer him any kind of treatment, because the patient will not tolerate those treatments. That is important. So general condition is very important, and for betterment of the general condition, the nutrition part is obviously is a major role here.
Okay. And one question Minaji asked to you, that is there any ideal body weight for the patient to undergo radiation therapy?
No, again, there is no ideal body weight. It is even no ideal height or BSA or BMI. Nothing is ideal, but the general condition. You can see is a BMI of less than 18 might be present with us with a, general condition is good and we are treating those patients. A BMI of around 25, that is the ideal BMI, everything is fine, but the general condition is very bad. We cannot treat the patient. So it is not any height, weight, or nothing else matter, only the general condition and the stage matter. Absolutely.
Okay, sir. Thank you very much. Minaji, anything else you want to ask? Then I have to check the questions of our viewers from the Facebook Live. Minaji, if you want to ask, you can ask the question to sir. Sir, we are already in Facebook Live, so many questions are coming, and and as you know that we are working in the awareness field. Is there any suggestion from your point of view, from your point that what are the points in which when we are going to our patient, when we are going to spread knowledge about sarcoma to the general people, what should be our main things, in which fields should we have to emphasis?
The important thing is that whenever any kind of any patient or normal person find any kind of lump in any
Yes.
part of the body, okay,
Yes.
so he or she shouldn't ignore those things. It might be oral cavity, it might be in scalp, it might be say female person breast, or in something wherever, in extremities, in leg, hand, wherever. If any kind of lump is there and this lump is growing, then he or she should go to any doctors available in the locally or wherever. Because if we avoid, if we just ignore those things, then it will increase. And if it is really a cancer or a sarcoma and ultimately coming to a non-resectable part or non-treatable thing, then ultimately it's going to be a, I mean, mess for that person now. So so it is important that any kind of lump in the body, so sarcoma mainly present with a lump, so any kind of lump, go to doctor. That's it. This is the idea. This is the first and last of the awareness.
हाँ, मतलब आप मैं हिंदी में थोड़ा बोलना चाहता हूँ कि बिकॉज वी हैव मेनी व्यूअर्स पैन इंडिया, दिस इज ब्रॉडकास्टिंग थ्रू ऑल ओवर इंडिया। मतलब आप जो बोलना चाहते हैं सर कि एनी काइंड ऑफ लम्प, अगर कुछ भी लम्प शरीर में दिखाई देता है तो we should not ignore that lump. We should always talk to and meet to any doctor. Am I right, sir?
एब्सोल्युटली, एकदम ठीक बोल रहे हो आप। सो आप नजदीकी वाले जो भी डॉक्टर साहब है आपके पास, तो
Yes.
आसपास में उसके पास जाइए, उसको दिखाइए और इलाज करना शुरू कर दीजिए। ठीक है, अगर आप घर में रहोगे तो इलाज भी नहीं होगा, बढ़ जाएगा और वो ट्रीटमेंट से पूरा बाहर हो जाएगा, हाथ से बाहर हो जाएगा।
और ऐसा भी तो है सर कि आज के दिन में कैंसर ऐसा नहीं है कि कैंसर हुआ है उसके मतलब सब कुछ खत्म, ऐसा तो नहीं है। सरकोमा भी है तो उसका भी ट्रीटमेंट हो सकता है। तो सर प्लीज हिंदी में एक बार आप जरा बोल दीजिएगा कि पेशेंट, ताकि पेशेंट थोड़ा पेशेंट को थोड़ा आशा मिल जाए कि थोड़ा प्लीज आप अगर बोल देते।
देखिए, जब सार्कोमा ये हो रहा है या कार्सिनोमा हो रहा है, जो भी हो रहा है, अगर अर्ली स्टेज में उसको पकड़ सकते हैं हम लोग, उसको इलाज कर सकते हैं, तो उस एकदम पूरा ठीक होने का संभावना होता है। पूरा एकदम, मैं बोल रहा हूँ फुल। वो पेशेंट 10 साल 15 साल बच सकते हैं। मगर वही अगर थोड़ा लेट हो जाए, 5 महीने 6 महीने 1 साल लेट हो रहा है ना, तो उसको ट्रीट करना बहुत ही मुश्किल होगा। उसमें टोटल सर्वाइवल और बचने का चांस जो है बहुत कम हो जाएगा। इसके लिए जब भी आप इग्नोर मत कीजिए, आपका जो भी सिम्टम हो रहा है, आपके जो भी आपको परेशानी हो रहा है, इग्नोर मत कीजिए, आसपास डॉक्टर साहब को वो बोलिए पहले।
Thank you very much, sir, because I know that you are very busy person, and उसके बाद भी आप बहुत ही समय दिए है हम लोगों का। We are very thankful to you, but we have some questions are coming that how long I think this question is already discussed, but still question is coming, so I am asking you that how long can a patient live after sarcoma? मतलब पेशेंट कितना दिन बच सकता है? नॉर्मली इस क्वेश्चन तो हम लोग को दिन भर सहना पड़ता है, तो ये इसमें हम लोग क्या बोलेंगे?
अर्ली स्टेज है, आप पूरा बच सकते हो, आपका नॉर्मल लाइफ एक्सपेक्टेंसी है। अगर ट्रीटमेंट करोगे तो पूरा बच सकते हो। अगर आप एडवांस स्टेज में आओगे तो ये बोलना बहुत मुश्किल है। उस टाइम बहुत कुछ, आई मीन स्टेजिंग एंड ग्रेडिंग, एवरीथिंग इज कमिंग, बट अर्ली स्टेज आप बच सकते हो। अच्छा,
और मतलब ये भी तो है कि ऑपरेशन सर्जरी जो आप बोल रहे थे, मैं आई एम स्पीकिंग इन द लैंग्वेज ऑफ लेमैन, दैट ऑपरेशन इज पॉसिबल एंड देयर इज नथिंग वरी इन गोइंग फॉर बायोप्सी और एनीथिंग। इसमें ये बात थोड़ा आप बोल दीजिए क्योंकि पेशेंट बायोप्सी करने में बहुत डर जाते हैं।
सो देखिए, हम लोग के शरीर में जो कैंसर होता है, मैक्सिमम कैंसर में ये बायोप्सी से फैलता नहीं है। एक दो जगह है, गॉल ब्लैडर है, टेस्टिकुलर कैंसर, एक दो जगह है जहां पे कभी कभी फैल सकता है, मगर इतना भी नहीं है कि पूरा एकदम फास्ट टू लास्ट स्टेज हो जाएगा, ऐसा भी नहीं है। मगर बाकी जो कैंसर है, मैक्सिमम 95% ऑफ द, और यू कैन से 98% ऑफ द सब कैंसर में बायोप्सी करना बहुत जरूरी है। ये बायोप्सी से बीमारी फैलता नहीं है। बायोप्सी से ये रोग जो है हम लोग ये डायग्नोस कर सकते हैं, उसको इलाज कर सकते हैं। उसके बाद बायोप्सी छोड़ के हम लोग ये बीमारी डायग्नोस नहीं कर सकता है। जब तक ये जो पैथोलॉजी का डॉक्टर साहब है वो नहीं बोलते हैं हम लोगों को कि ये कैंसर है, हम लोग तब तक कुछ नहीं कर सकते। और वो या एफएनएसी जो भी है वो करेंगे। सो एक जो टिश्यू है कैंसर से, वो लेना बहुत जरूरी है। तो आप घबराइए मत, ऐसा कुछ हो रहा है लंप या कुछ भी, आप जाइए बायोप्सी बेझिझक करिए, कोई दिक्कत नहीं है उसमें।
Thank you, sir. Thank you once again. Thank you, Meena ji. I am going to conclude this session. It is a very much knowledgeable session for our viewers and for me personally also. See, I like to conclude with one thing that DS Research Center already we have a motto that our main motto is to free cancer world. This is our as a dream. And we believe that and we always say that let's save our world from cancer, and we also believe that yes, together we can, and we are working on that. We are working on different kinds of awareness program. This is also an awareness program. We are going to the many fields, many rural areas, many areas, and we are seeing many kind of cancer patient, not only not today, for many years, since many years back we are doing that job. And so lastly, I thank you all again, and my from my heart there is only one message, sir, that, and Minaji also, that tamosoma jyotirgomayo mitorgomayo, every patient will get some kind of recovery from treatment. Every treatment is essential, sir. Thank you very much, sir. Anything else you want to say to our viewers or patients, sir? Anything else you want to say?
No, again the same. If any doctors here present, then I like to say that don't forget, because the life of one patient is also important for you.
Yes,
I mean,
yes,
for the
sir.
doctor.
Yes, sir.
So whether it's a rare or not, don't care. Just go through it, diagnose it, and treat the patient. So this is important for the doctors and for the patient. Yes, you have find anything, don't forget to come to any kind of doctors.
Yes, this is a very important message. If you find anything abnormal, if you feeling anything abnormal, always consult with doctors, and they will help you. This is a very important message from the from our doctor, our very special guest today, and we believe that in future also we will get a chance to have your time, sir, and we will. Okay, sir. Thank you, and we will arrange this kind of programs, this kind of medical education program for all our viewers. Thank you very much. Thank you very much once again, Meenaji. Thank you all. Thank you, Dr. Shamrat, for coordinating everything. Thank you, our technicals, Subhadeep and others. Thank you, our admins, people like Manishji and all of us. Thank you to everybody. Thank you all. Thank you, our viewers.
Thank you.